Okay, should we start or wait for 2-3 minutes? People are just joining. We'll wait for a few minutes.
Wait for 5 minutes.
Yeah.
Give time for people to join.
So can I make a statement here regarding these vaccine-induced neurological complications? Dr. Surya, sir?
We will talk
Rajesh,
offline. Offline we'll talk.
Later on, because now we have made it live.
Okay, sir.
So what is the temperature, Shripad, in Pune now? And Rajesh, the Lucknow is hotting up?
It's quite cold, sir.
No, hotting up for the election.
Politics is basically Dr. Kalyan's initiative, and
So because of rainfall at adjacent hilly areas like Uttarakhand, so it's a sort of chilly cold for last 3 or 4 days.
No, here in Maharashtra, I think we are seeing a very unusual January, not seen in last so many years. Such cold wave.
It's cold wave at Maharashtra. At Mumbai also.
Yeah, even in Mumbai.
It is very unusual actually.
Mumbai is better now. It's getting warm now. But it was for 3 days, it was cold.
It all because of climatic change.
Yeah.
Throughout the globe.
So Mishram, you start at 5:05. So 2 more minutes. Secretary General has joined, so welcome him.
Good evening. Good evening.
Good evening, Minashi.
Good evening, sir.
Good evening, sir.
Good evening, Rajesh.
Good evening, sir. Good evening, sir.
Manish.
Good evening, sir.
Good evening, Sripad.
Mishram sir, are there any specific measures which have been adapted on this World Neglected Tropical Diseases Day? I mean to say, they have started focusing on neurocystic cirrhosis as one of the major challenges and a problem. But have they, come with any concrete slogan or any concrete?
No concrete slogan.
Okay. Because
we have because the problems in different regions would be different.
I know, but cystic cirrhosis was mentioned as one of the foremost neglected tropical disease with the high disease burden world across. So one of the topmost diseases which need to be dealt on priority. And,
therefore we have included cystic cirrhosis, dengue.
Measures like just preventing open defecation and other things itself, is a big challenge.
But you are not visible.
He will be joining. I have sent him a notification. I think Dr. Devashish is who you're talking to.
Dr. Sita, good evening.
Sir, good evening, sir. Good evening.
I'm glad Sita is here.
Dr. Ruikar,
he
has joined. Sunny Pillai joins.
Chandrasekhar, we should start.
Good evening.
Yeah, we'll start. On behalf of Indian Academy of Neurology and Tropical Neurology subsection of Indian Academy of Neurology, I welcome you all for this public education program on occasion of World Neglected Tropical Diseases Day. Now, what are these neglected diseases? The common entities, as we call them, are cysticercosis, dengue, chikungunya, Chagas disease, dracunculosis, it is called guinea worm disease. It's seen mainly in the African region. Echinococcosis, human African trypanosomiasis, also called sleeping sickness, leishmaniasis, leprosy, elephantiasis or filariasis, onchocerciasis or river blindness, rabies, scabies, schistosomiasis. So there are about 20 odd neglected tropical diseases. And these diseases are neglected because they are almost absent from the global health agenda. Now, what is in the global health agenda is hypertension, diabetes, heart attack, stroke, HIV, dementia, etc. But these important diseases are absent from the global agenda. Now, for neglected tropical diseases, there is a little funding. It is as low as 0.6%, though these occur in about 30 to 40% population of the world and are associated with stigma and social discrimination. These are diseases of neglected population, which are poor socioeconomically and educationally, and these are backward regions. So to create an impact, a brand of neglected tropical diseases was created by the people who are working for these. The COVID-19 pandemic, the impact has become very severe as the people are further struck by poverty. Many have lost their jobs, many have lost their near and dear ones. Now, public education is an important part for recognition, early treatment, and prevention of these diseases. Now, print media has been very proactive in this campaign, and I would like to thank them wholeheartedly. Print coverage of these activities in India is best in the world. We have distinguished panelists to enlighten you and welcome all the panelists. To inaugurate today's session, we have Dr. Nirmal Surya, President of Indian Academy of Neurology, a very dynamic president. He's a chairman of Epilepsy Foundation. He has done many camps for last many years on epilepsy throughout Maharashtra. And he is very well known all over the Maharashtra, all over country. He's a consultant neurologist at Bombay Hospital, Mumbai. He was treasurer of Indian Academy of Neurology for 6 years. He organized a World Congress of World Federation of Neurorehabilitation in Mumbai. He is president of Indian Federation of Neurorehabilitation. He is a past chairman of Tropical Neurology subsection of Indian Academy of Neurology. He is vice president of Asia Oceanic region of Neurorehabilitation Society. He does a lot of social activities. He received many awards for this. And for this year, today is the first activity, but he has planned about 25 public education activities throughout the year. Welcome, Professor Nirmal Surya. The moderator for today's session is Dr. Rahul Purkarni. He is the chairman of a Tropical Neurology subsection of Indian Academy of Neurology. He is a consultant neurologist at Dinanath Mangeshkar Hospital in Pune. He has a lot of experience, especially in infective diseases, including dengue and chikungunya, and he did a lot of research work and publications, and he is a hardcore teacher. I also welcome Secretary of Indian Academy of Neurology, Professor U. Meenakshi Sundaram, EC member of Indian Academy of Neurology, Dr. Sita Jailakshmi, and welcome all the panelists. I welcome you all once again. And now I invite IN President Dr. Nilmar Surya to inaugurate the session. Dr. Surya, please.
Namaskar. Thank you, Chandrasekhar, Tropical Neurology Subsection Chair and Convener, Dr. Rahul Purkarni and Manish, Secretary, Indian Academy of Neurology, Dr. Meenakshi Sundaram, EC member, Dr. Sita Jailakshmi, my panelists present here, Debashish, Sripad, and Dr. Verma. All the attendees, which also include many doctors from Indian Academy of Neurology and others. It's indeed is a pleasure to be here for the first action plan of the public activity, which takes off on an important day. Important day because these are the diseases no one talk about. Chandrasekhar had listed you about 20 of them, but there are some of them which are quite prevalent in country like India, like rabies, leprosy, dengue, and chikungunya, and of course the cystic sarcosis. And today the panelists are going to focus on a couple of these diseases more specifically to bring you an update and how to deal with them. Everybody was worried in between about COVID, and then suddenly we realized that fever, which was hiking all over the country, was because of dengue, because of the rain season which started. And dengue itself is a very fatal disease, and I'm sure the panelists will highlight that how to prevent a simple infection in our country. They will also highlight on certain other disorders. What is important thing is whether it is dengue, whether it is chikungunya, whether it is cystic sarcosis, they all can be prevented. So all these diseases which has got so high number in our country, if a proper measures can be taken, can be prevented, and our panelists will really highlight on you on these aspects that will help you. Indian Academy of Neurology has taken this a very important agenda to reach out to the common people and make them aware about the various disorders on those days. Our next program will be on epilepsy, on World Epilepsy Day. That will be on 14 February. And I'm sure you will find that also very, very interesting. So we will continue to have similar program every month or maybe twice a month, depending on the particular day. And Indian Academy of Neurology is also not only for public, but also making awareness and training program, not only for physician, the general practitioner, and the neurological student. So all around, we want to create an atmosphere where people are aware about the common disorders, common neurological diseases, and in turn, a dialogue between the common people and the expert could be created so that people know exactly what is to be done and how to be given the guidelines during those problems. I want to congratulate Dr. Chandrasekhar Meshram, who has been actively working for past many years on tropical neurology section of the World Federation of Neurology. And I'm sure tropical neurology is one of the most active subsection of Indian Academy of Neurology. I have for a brief period was involved with tropical neurology subsection as chair, but now Rahul Purkarni and Sripad Pujari is Manish Modi has been taking further, and I'm sure you will see them again and again because tropical neurology subsection is going to create a couple of sessions on various disorders. So I give them best wishes. I will request them that every time they should get new people into the panel so that the many more youngsters get the opportunity to interact with the panels and common public. With that note, I wish you all the best, and I thank you, Dr. Meshram, for your involvement and your elevation in the World Federation of Neurology as the trustee. So that's a great, proud moment for us, and congratulate you on that particular note. With that, best wishes, and I'm sure this 1.5 hour session will get you some very, very interesting facts, and you will know how to prevent these diseases. Thank you very much. Namaskar.
Namaskar. Thank you very much, Dr. Nirmal Surya, for those kind words and wonderful address. Now over to Rahul Purkarni. Rahul.
Thank you, sir. Thank you. And I welcome you all for this meeting. It's going to be a question answer or a panel discussion kind of meeting rather than we are showing slides, because it's going to be a public education program. You can also answer sometimes in Hindi if you wish so, but preferably you better answer in English. There will be certain questions which can be asked through the panel. There will be certain questions which can be asked through the Q&A box, which probably will be asking. So we'll start with dengue. Though, as Dr. Meshram as well as Dr. Surya said, we know that dengue is one of the leading diseases in the country, and probably not a single part of country which has not been affected by dengue. Unlike COVID, this is a disease which also is predominantly very active in children as well as. So from pediatric to geriatric, everyone can be affected by this disease, and we have been seeing this disease for more than a decade now, and I'm sure all the neurologists have seen tons of cases of dengue. So we'll start with dengue. Of course, before I start, I would introduce the panel which is going to be here. So we have Dr. Manish Modi, who is the professor of neurology at PGI Chandigarh, who is also the convener of the neurology subsection, tropical neurology subsection of IN. And he also will be moderating a session on neurocystic cirrhosis in the later part. Then we have Dr. Rajesh Verma, who is a professor of neurology at KGMC Lucknow. We have Dr. Gagandeep Singh, who will be joining us, whom we know is the president-elect of Indian Academy of Neurology, who also comes from, he is a professor of neurology at Dayanand College, Ludhiana. We have Dr. Shripat Pujari, who is consultant neurologist at Dinanath Mangeshkar Hospital and Nobel Hospital in Pune. And we also have Dr. Devashish Roikar, who is a consultant neurologist from Latur. So this is a group that we have here. So I'll start with certain question and we'll go about the question. So let me start with the first question. We'll ask the question of course, usually it will be targeted to one person, but others also can answer the question if they want to add up something. So I would like to start from Dr. Shripat Pujari. So Shripat, can you tell something about what is dengue and what causes it? Some basic things about dengue. So over to you, Dr. Shripat Pujari.
यस मैं हिंदी में बात करूंगा ताकि सबके लिए वो कॉमन भाषा है. सो जैसे हम देख रहे हैं, कोविड एक वायरस यानी विषाणु से हुई बीमारी है. उसी तरीके से डेंगू भी एक वायरस है, विषाणु है, लेकिन वो फैलने का तरीका कोविड से बहुत अलग है. हम सब मलेरिया जानते हैं, जो मच्छरों से एक दूसरे से फैलता है. मलेरिया से पीड़ित रुग्ण को एक मच्छर काटता है, उससे वही मच्छर अगर दूसरे रुग्ण को काटेगा तो उससे मलेरिया फैलता है. एग्जैक्टली उसी तरीके से डेंगू भी एडिस नाम का एक मच्छर है, उससे यह फैलता है. डेंगू ग्रस्त रुग्ण से दूसरे को अगर वो काटेगा तो उसके खून से वो काटने के बाद दूसरे इंसान में घुसकर फिर वो डेंगू दूसरे इंसान को हो जाता है. और बाकी जो उसकी लक्षण है वो बाकी के सवाल में आपको सवाल जवाबों में समझ में आएगी. और इसलिए बहुत महत्वपूर्ण है कि हम पानी का जो साठा है वो ना एक जगह इकट्ठा हुए. अगर नहीं होता है तो वो मच्छर नहीं उसका प्रजनन नहीं होता और डेंगू का होना और फैलना उससे टल जाता है. Dr. Kulkarni?
Yes, so indeed we know that dengue is a disease which is caused because of bite, because of the mosquito. And of course, we know that the mosquito is usually seen more in urban areas. So this was of course more common in urban areas. And कहीं भी थोड़ा भी water अगर accumulate होता है, तो we know that this virus can be seen in this water because of the eggs laden by the mosquitoes in this water. So over to Dr. Devashish Roikar, can you tell something about common features of dengue? Not neurological, just the common features for layman to know कि किसी वजह से dengue हो सकता है. What are the symptoms of dengue? So Devashish.
Yes, sir. At the outset, I sincerely thanks the entire IN team, Dr. Nirmal Surya sir and Dr. Rahul Purkarni sir especially for the nice webinar and nice initiative. एक्चुअली जो डेंगू होता है, जैसे हम अभी डिस्कस कर रहे थे कि मच्छरों के काटने से, मच्छरों के काटने के जैसे मैक्सिमम टाइम मच्छर बच्चों को ज़्यादा काटते हैं, स्पेशली इन दी whenever they play with उनके पास अगर ऑन देयर ओपन सर्फेसेस, कभी कभी कोई खेत में काम कर रहा है वहाँ काटते हैं। हालांकि जो स्पेशली डेंगू का मच्छर है वो सुबह में और शाम के टाइम ज़्यादा काटने का माना जाता है, स्पेशली मॉर्निंग 6 to 10 and evening at the dusk time. Otherwise, it is called as tiger mosquito and it can just come and bite you at any point of time. तो ये डेंगू मच्छरों के काटने से होता है। दैट टू अगर आप पूरे कपड़े पहने तो आपको काटने का चांस कम रहेगा। अगर आपके कपड़े कम है तो जहाँ भी कपड़े कम है वहाँ वो आके टाइगर मस्किटो काटने का चांस आपको थोड़ा सा ज़्यादा रहेगा। तो जनरली अगर पहली बार अगर डेंगू होता है तो हमेशा थोड़ा सा वायरल फीवर जैसा बुखार आएगा, कभी कभी कम बुखार आएगा, कभी तेज बुखार आएगा एंड कभी कभी बहुत ज़्यादा बुखार आएगा। इनिशियल टाइम को उसको कभी बोन ब्रेकिंग फीवर भी बोला जाता था, यानी इतना बुखार और इतना पेन होता था कि जैसे हड्डियों तक आपको बुखार महसूस हो रहा है। सो इट इज कॉल्ड एज बोन ब्रेकिंग फीवर। आमतौर पे जॉइंट्स का दर्द भी होता है, मल्टीपल जॉइंट पेन्स होते हैं डेंगू के टाइम। और पहला टाइम जनरली ऐसे होता है। डेंगू के 4 सीरोटाइप्स माने जाते हैं, डेन 1, डेन 2, डेन 3 एंड डेन 4। अगर डेन 1 आपके एनवायरनमेंट में घूम रहा है एज ए एंडेमिक तो डेन 2, डेन 3, डेन 4 नहीं घूमते। लेकिन अगर आपको एक बार डेन 1 के इन्फेक्शन हो गया और सेकंड टाइम आपको मॉस्किटो काटता है, कभी मे भी 2 साल के बाद, 3 साल के बाद, तो आपको अगर सेकंड टाइम भी डेंगू होता है तो शायद ये हो सकता है कि आपको बहुत सीवियर इन्फेक्शन हो जाए, जिसको डेंगू शॉक सिंड्रोम बोला जाता है। उस टाइम प्लेटलेट्स कम होते हैं, आदमी का बीपी कम हो जाता है, सूजन चढ़ जाती है, सांस लग जाती है, पेट के अंदर थोड़ा पानी भर जाता है, कभी कभी लीवर का थोड़ा काम कम होकर आदमी को पीलिया हो सकता है। और आमतौर पे ब्रेन का इन्वॉल्वमेंट कम होता है। ब्रेन का इन्वॉल्वमेंट हालांकि लेस देन 10% या अराउंड 10% लोगों में होता है, 90% लोगों में ये सब होता है। डेंगू शॉक सिंड्रोम जानलेवा कंडीशन मानी जाती है। और जब अगर बीपी कंटिन्यूसली कम रहा, उसका प्लेटलेट कम हो गया, तो शरीर में कहीं कहीं खून का रिसाव होकर बीपी कम होकर उसके बाकी जगह पे हार के एक अराउंड 10 to 30% चांस है कि आदमी की मौत भी हो जा सकती है। और ये बच्चों से बूढ़ों तक हर उम्र में इसका रिस्क उतना ही होता है। तो बेसिकली डेंगू इनिशियल फेज में होगा, अगर सेकेंड टाइम होगा तो कभी कभी आपको काफी सीवियर तरह से हो सकता है। तो डेंगू फीवर या डेंगू शॉक सिंड्रोम ये उससे कॉमन मैसेज। और काफी लोगों को पता है कि डेंगू इज कॉमनली एसोसिएटेड विद थ्रोम्बोसाइटोपेनिया। तो अगर डेंगू हो गया तो काफी टाइम प्लेटलेट्स कम हो सकते हैं, वो कभी कभी काफी कम हो जाते हैं। तो कुछ लोगों को खून के स्पेशली प्लेटलेट्स जैसे कंटेंट या कभी इफेक्ट देना पड़ सकता है। ओवर टू यू सर। थैंक यू।
Thank you, Dr. Devashish. So now we know that dengue is a disease which is a viral disease and it can cause a lot of viral symptoms, viral features, but it is also a virus which can affect brain. That is why actually we have kept the meeting for the neurologists. And to answer this question about what is a neurological feature or what are the neurological features of dengue, we have Dr. Rajesh Verma, who has done a lot of work about neurology of dengue. So Verma ji, we all know that you are an expert and master in neurology of dengue. So can you tell us what are the various neurological features of dengue that are known and what are the ones which you have seen and what you want to tell to common people about the neurology of dengue? So over to you.
First, I would like to convey my gratitude to tropical office bearers to give me this opportunity in this great panel discussion about this neglected tropical diseases. Yes, regarding neurological complications, I think the plethora of publications in the recent past, maybe for the last 1.5 or 2 decades, neurological complications occur in dengue illness in around 6 to 10% of the patients. And various type of neurological complications have been reported so far. And we can divide into 2 parts. One is central nervous system, CNS complications, and peripheral nervous system complications. So CNS complications mainly are encephalitis. Initially, it was thought that probably it is not neurotropic virus, but now with the, I would say, various procedures, maneuvers, we are able to find this viral antibodies in the CSO or sometimes antigen, even with some autopsy studies. So it can cause a sort of direct neurotropism causing encephalitis. The second is encephalopathy, which is found in fair number of patients of dengue fever. Then stroke-like illness, both types of stroke, ischemic stroke as well as hemorrhagic stroke can occur with dengue fever. Of course, acute disseminated encephalomyelitis and acute transverse or myelitis. So these are the common CNS complications. But peripheral nervous system complications, so we get almost all type of PNS complications, starting from peripheral neuropathy like Guillain-Barré syndrome, and then brachial neuritis or neuralgic amyotrophy like illness. Then hypokalemic, it is associated with hypokalemic paralysis, sometimes with diaphragmatic palsy and myositis, dengue myositis. So these are the well-reported complications across the globe. But sometimes it can also cause some ophthalmic complications, maybe maculopathies or like that, and sometimes neuroenamel-like syndrome. So these are the common complications of dengue fever, neurological complications.
Yes, thank you. Because we are talking about neurology, anyone else wants to add up something? I would also like to say that yes, indeed, it's a common disease where neurological manifestations are being seen, because the sheer number of dengue patients are so high that we are seeing a lot of neurological complications. One important thing that we had seen often in our practice is not a classic neurological manifestation, but syncope, जिसको कि हम लोग चक्कर बोलते हैं या जिसको fainting बोलते हैं. It's very common with dengue because they develop hypotension, shock hota hai, and then many times they faint. And actually, fainting was seen as one of the features jiske karan patients were brought to the hospital, and then investigation has shown that they had dengue. Of course, syncope is not a very classic neurological disease, but many times it is missed as kuch zyada serious problem hai. So one shouldn't forget that syncope or fainting also is a common feature in dengue. Yes, so as Dr. Verma said, we see everything with dengue. From nervous problem, from nerves problem, from spinal cord problem, convulsions, encephalitis, encephalopathy. And now there are various patterns of encephalitis which are also been described. Initially, aisa lagta tha ki dengue is not going to cause any brain problem. The brain problem in dengue was indirect, but because of large number of papers mainly from India, and I would say also large number of papers from Dr. Verma, we know that it's a virus which can affect brain. And there's no doubt that this is an important virus in India, which can cause brain-related problems. So now I would like to ask Dr. Manish Modi about if you want to say something about treatment. So Dr. Manish. Manish, are you there?
So before that, can I make a comment about pathogenesis? If
yes, please, go ahead, please.
So pathogenesis, what we say, we divide it into three parts. The one is direct or neurotropic illness like encephalitis, myelitis, edema, and sometimes myositis. Other is immune-mediated inflammatory disorder, and maybe this GV syndrome or neuralgic amyotrophy, brachial neuritis. So, and then systemic manifestations because of liver dysfunction, renal dysfunction, electrolyte disturbances, thrombocytopenia. So, all these are the three common mode of pathogenic mechanism leading to various neurological complications.
Right. Okay. Manish, would you like to say something about treatment?
Yeah, 2-3 points for general public. Dengue. सभी ने कोविड का जलवा देखा है, डेंगी ने इस बार सबको जलवा दिखाया है. As doctors pointed out earlier also, there had been a lot of problem in the initial part during the COVID wave, only when a lot of people started having high-grade fever. And it was really, a great burden on the health services to, tackle both COVID and dengue at the same time. And it is very unfortunate. A disease which is totally preventable. This tiger mosquito, it is called tiger mosquito. It is a very lazy mosquito. It cannot fly very long distances. It wants to be just very near to you, So you are yourself the culprit for your disease. That is what I want to say. I want to emphasize, because it's a neglected tropical disease. It's a disease of, I will still say, poverty, unplanned growth, improper sanitization, improper disposal of water, stagnation of water. You are giving breeding space to the mosquitoes, and a disease which is totally preventable. Where do you see in America or in any developed country? Hardly ever. Why? Because of the maintenance of hygiene. So I'd say with this group, the Swachh Bharat mission which the government has started, everybody should start, responsibly participate, at least take care of your surroundings. If your houses, I'll say, if your house and your house surroundings are protected, I can tell you we are all protected. If everybody of us take care just around our house, on our rooftops, in our backyards, in our front yards, we prevent stagnation during rainy season. I'm sure we can, bring it to a level where it doesn't become a public health problem. It had been a big problem. We spend so much on hospitalization. Each patient is paying 50,000, 1 lakh, 2 lakh, 3 lakhs for hospitalization. And we just can't manage 300 rupees per month to just, keep things away from stagnation of water. So this is my take-home message for this deadly disease. The only way to prevent is prevent mosquito breeding. And the only way is prevent stagnation of water just around your house. Don't forget about your neighborhood. Just motivate them that you just take care of your water logging. Your problem of dengue is over. And this is a perpetual problem, because India is prone to, having rainfalls for long duration, as we can see even this time also. The problem had been that there had been unexpected, too much of rainfall, so much of water stagnation, and the mosquito found its way. It was interesting how to control the mosquito. This was the simplest way. People have started infecting the mosquito with a very funny. I was reading a bacteria. So how to take care of the mosquito? You infect them with a bacteria called Wolbachia. So I was finding it very interesting. So people have used that as a eradication for dengue. They infect the mosquito with bacteria. It cannot get the virus. So you are free from chikungunya. You are free from dengue. You are free from so many viral infections spread by mosquitoes. So I'm just telling, the problem is big, but the solution is very simple. So we as team leaders must, propose this or make aware. It is not just the responsibility of the government. Even we as physicians have equal responsibility. In addition to cure, just this simple message of, prevent waterlogging. A simple slogan can prevent thousands and thousands of deaths and millions of rupees, which we are spending on this preventable disease. That's my major take-home message for this neglected tropical disease. Thank you.
Manish, would you like to comment something about the vaccines?
Yeah, I wanted that. I was looking at, where COVID, when COVID came, the whole world, went for, because the West was involved, the US was involved, the Europe was involved, everybody was involved. So we got the vaccine. No, not 1, 2, 3, many of them. There was plethora. Billions of dollars were spent on this because that was the priority of a developed world. Now this is a developing disease, developing country disease problem. No vaccine. There had been one proposed by Sanofi that was launched in 2016 or 17, but because in a patient who is pre-exposed, it may lead to serious complications if he is exposed again. That is what I could make out from literature. So it was never allowed in India because of this. Now, recently I was reading that some Japanese firm has already come up with a new vaccine, which takes care of all DEN 1, 2, 3, 4, has already been told by the panelists. And of late, 2 or 3 firms from India itself have also cracked the code. And there is not for that maybe the clinical trials, if they start, I wish they start at the pace of COVID. Maybe next year we may find the light of the day, at least they come in the clinical trials, if not for public use. So that will also be a big, say shot in our arm, at least to prevent some major complications and to prevent some deaths. And but again, I'm sure the burden will be much more higher. That will not, take us away from the fact that we have to prevent proactively mosquito breeding, which is leading not only to just dengue, it is the same virus mosquito is for chikungunya also. And we are not, there are reports that a person has been infected with both chikungunya and dengue simultaneously because both are spread by Aedes mosquito. So I mean to say, ultimately prevention is the only cure to my understanding and to everybody's understanding, and that has to be highlighted. We have to be very careful about our surroundings. Thank you very much.
So can I make comment here regarding vaccination of dengue?
Yes, please go ahead.
I think WHO and other agencies strongly recommend that vaccination should only be used in endemic zones, number one, where there are already patients, community at large are exposed to this dengue infection, because if it is the second time vaccination, first infection and then vaccination, so it will not lead to that type of serious complications, which we know as antibody dependent enhancement or lethal disease with different serotype. So I think these are the, but I don't know exactly so national control program or this neglected tropical disease control program. So what, in fact, they are thinking of massive vaccination in India about dengue fever.
So as of now, we know that there is no much vaccine.
I don't think it is still commercially available or for public use as of now. Not any of it is not cleared by DCGI for public use as of now. Verma sir?
I'm also not aware.
No,
so
I don't
whether
think so. It has not been,
but
because I was reviewing it after I discussed with Dr. Rahul that people may be interested in, is there everybody had been looking forward. Everybody, including all of us, had been looking forward for vaccine that at least it couldn't prevent infection, at least it could save lives. Everybody of us have witnessed that. So we want such kind of, sea change in the outlook of dengue and chikungunya mortality also. So proposals are there. They are at a very, very advanced stage. That is what I could make out. And they are at the stage where they are ready for the human trials. But not yet. DCGI has not approved even the Japanese one also. They applied it last year in October, but they have not got any clearance or anything from Government of India as of now. But to my understanding, 3 or 4 firms from different parts. One is in Hyderabad who are actively pursuing this vaccine, and I'm sure they will definitely get a big breakthrough.
Yeah. So as of now, there is no vaccine.
As of now, it is not there.
The Sanofi vaccine was approved in US in 2019, but it's really not a vaccine which has really made wonders, unlike other vaccines.
No. It may rather was causing complications, so it was never given DCGI approval.
True.
The vaccine was also advocated only in children from 9 to 16 years of age.
Yes,
right, sir.
Anyone wants to comment about treatment, because there are a couple of questions which have been asked on treatment of dengue. If anyone wants to comment on use of steroids or antiviral drugs, we know that of course there are a large number of antiviral drugs which are available in world, but unfortunately they are useful either in herpes virus or in HIV virus or now in coronavirus. The big chunk that we see in our part, that is arbovirus, there are hardly any drugs which are useful in arbovirus. So no drug for JE, no drug for chikungunya, no drug for dengue. So none of us have used the cyclovirs or whatever large number of drugs which have been used. So no drug as far as I know. Anyone wants to comment about steroids, because that's one thing that people would definitely like to ask. So Dr. Verma, Dr. Manish, Dr. Shripad,
I just want to you have raised a good point. You must have seen, Rahul, and all of us, that the fever, like in COVID also, at times doesn't settle down, and at times we prefer to use NSAIDs, maybe naproxen or Neftal or something like that. So what I wanted to highlight is that if the suspicion of dengue is strong, as we always prescribe Dolo, but Dolo, or paracetamol doesn't alone give a relief to fever, and people always look for fast relief from fever. So NSAIDs, if suspicion of dengue is strong, the take-home message still remains that it has to be Dolo until and unless we know what is the underlying cause for your. See, if it is chikungunya, I give you the example. Nothing settles except for naproxen. All of you must have seen that. Such severe joint pains, they won't budge with paracetamol.
Talk about chikungunya, Manish, afterwards.
Yeah, I'm just saying. So there the NSAIDs may be an indication. But when it comes to dengue, NSAIDs is a big no. So that is what I want to highlight, that if the diagnosis is not yet confirmed and the diagnosis of dengue is in great suspicion, then we should emphasize to our patients that they should not take anything else except for Dolo or paracetamol. Thank you.
Yeah, another important aspect that people are worried about, the platelet count, the low platelet count. And though there is a platelet count drops in, we don't see much of intracellular hemorrhage, even with 15,000 or 10,000 platelet count. So that is one important aspect, though there is a peripheral bleeding. And someone can comment about what to do for this low platelet count and what to do.
So if there is a low platelet count, if there is a clinical bleeding is there, then possibly we can use the SDP or RDP. If the clinical no bleeding is there, most of the time nowadays people are not preferring giving SDP or RDP. And regarding steroid, it is commonly seen in day-to-day practice, like I practice, and 70% of our populations are from rural India. So here it is a very common practice to use steroids, and somehow we discourage to use steroids in dengue encephalitis because its role is never proven. But almost everybody gets having dengue some sort of steroid, either usko platelet kam hai bolke or something like that. But I want to discuss with the panel how much is the role of steroids in the dengue encephalitis, but it is officially, it is not proven. It is not recommended, not in any guidelines, and not this thing, but it is practically used for majority of the GPs and physicians.
So can I comment here? Can I comment here, sir?
Yeah, Dr.
I think the treatment of dengue is basically, or the neurological complication of dengue is a meticulous management of dengue fever. And because, and there are only 3 or 4 very important determinants to control dengue fever. One is don't use NSAID because it can give rise to bleeding complications. Number 2, take a lot of fluids. Basically, there is a plasma leakage syndromes, so you have to replete with a lot of fluids to the patient. And then, of course, you should know what are the hardcore features of dengue fever. So the retroorbital pain, severe myalgia, rash, fever is, it can be, but retroorbital pain and severe myalgia, basically one should suspect dengue fever. Regarding use of steroids per se in dengue fever, there is no role of steroids as far as what literature advocates. But in neurological complications, of course, where steroids are already indicated, just like in neuralgic myotrophy, or sometimes in acute disseminated encephalopathy, where we suspect immune-mediated inflammatory neurological complications. Of course, steroids are having some specific role to play, because even without dengue, if these complications are occurring because of some other viruses or because of some other agents, of course, we treat these patients with immunomodulators or immunosuppressants to take care of inflammation. So steroids are specifically used for those conditions where we have high index of suspicion for immune-mediated inflammatory neurological complications.
So I agree with you that the spectrum of so-called dengue encephalitis may encompass many disorders. And recently we tried to analyze our cases and could come up with some kind of classification. One of the part of it may be direct viral neurotropism. One of it may be because of the acute necrotizing encephalitis, where there can be some role of immunological treatment. And some of it may be post-infectious or para-infectious, where again immunological therapies may be useful. Now we do not know how much of it is directly because of virus and how much is because of the immunological mechanism. We need some more robust immunological data onto it. If some of the cases are immune mediated, then of course immune therapies, including steroids or maybe immunoglobulins, may be beneficial, but we need some more data. So it's such a common disease, but still, we keep saying that we need vaccines. There's no treatment. We need more data. We are working on it. So it's a disease which is still requiring a lot of efforts from our end. And it is our Indian disease. We must work on it. And I think it's a disease for which the tropical neurology or the Indian Academy on the larger perspective must be serious to work on this, to find out some guidelines, to some efforts on the prevention as well as management of these disorders. So I think we move on to the next disease. So let's talk about chikungunya. This is a disease which came to India about 15 years back. When the disease came to India, no one was knowing what is the spelling of the disease per se. I started typing chicken and I could not find out this disease. And then I didn't know how to spell the disease also. In 2006, first time we saw the cases. The first cases we had were all from Africa and the Mauritius and maybe the French Reunion Islands. And then it just stuck the India. The wave was as massive as COVID, but of course it didn't last as long. And all of us saw a lot of neurological complications that time. We know that the spelling of chikungunya is a rare African word, which is for the arthropathy that we see, where the bones are bent because of severe arthritis. So let's start about chikungunya. So Dr. Verma, would you like to say what are the common features of chikungunya for the normal people? क्या होता है चिकनगुनिया के लक्षण? Simple words.
I think some other specialists should give us this opportunity.
So Sripad, would you like to, sir, Meshram sir, would you like to see? Sir has written recently something on chikungunya. Sir, something on chikungunya. Nagpur was well hit with chikungunya. So क्या आपको बताना है?
नहीं, what chikungunya is mainly affects the, as the word says that you bend. Most of the people have very severely affected with joint pain and the steep joints, and that really lasts for a very long time. It's a very disabling disease. वो बहुत से patient ऐसे होते हैं कि, and so many people in the family get affected. The whole society or the villages get affected, and there is so much of fever, arthralgia, joint pains. These are the common manifestations. But these patients also have a neurological manifestation, and that I think we can discuss later. But the common thing is the very severe joint pains. Some patients even have weakness in the legs and neuropathies, myelopathy, encephalopathy, all kind of complications. Again, which is another viral disease transmitted by mosquitoes, same type of mosquitoes which causes dengue, and it has been endemic in different regions and different states throughout the country. And from 2005-06, we had a very severe epidemic, but it has not gone. It is still existing. Sometimes it affects north, sometimes it affects south, sometimes this state or that state, but it is just going on. And we need to, I think, take care of mosquitoes. And then Manish was saying that the mosquitoes, the tackling of mosquitoes is important, but the mosquito is more intelligent than the human being. And it, gets into genetic, mutation. It changes itself. So you have some medicine for mosquito, it changes its genetic, and it becomes resistant to that particular treatment.
Right. So we know that, chikungunya was in India probably in 60s, mid 60s it was in India. And that was a virus which was from the Asian lineage which came to India. It was a very mild disease at that time, never thought to be neurotropic. But then this new virus which came from Africa, this was an African lenient virus which came to India in 2006, 2005, 2006, started from Africa. It came to the Southeast islands, including Mauritius, and started from Madagascar, Mauritius, and then came to India, started from Kerala, and then went up and up and up to the north. It was really, all of us had no immunity against this virus, so it stuck us hard, though it was not as severe as COVID because it came through a mosquito, not through our sneezing or coughing, but it did affect us. And now it has become an endemic virus in the country. So it started as an epidemic, and then it's remained an endemic. Probably this is how COVID is going to last in our country. Everyone is hoping in this way. So this is a virus which we saw a lot of cases. We did publish a couple of papers on this. We know that this is a virus, again, like dengue, starts from brain going up to muscles or nerves. So it can cause encephalitis. The encephalitis here was very common disease, and we could see a different kind of encephalitis where there were some MRI changes which were unusual for this virus, where we saw a lot of dots on MRI, which is called a diffusion MRI, जिसमें कि dots दिखे थे. So which was an unusual MRI in this disease. Similar MRI was also seen with Zika virus encephalitis. So both these Zika and Chikungunya are a similar kind of viruses. Then we had lots of patients of myelitis. We had neuropathies. So all complications were known with Chikungunya. Of course, the common complication that we see nowadays is, of course, the carpal tunnel syndrome, jahan ki because of arthritis, the nerves are pressed near your wrist and you get tingling in the hands and legs. So neuropathies because of compression are very common in Chikungunya. So occasionally we see nowadays patients of encephalitis, we see some patients of neuropathies, we see some patients with a lot of myalgia, and of course the carpal tunnel syndrome. So it has been there. It is the cases are seen as Meshram sir said, come in crops, and we do see these kind of cases. So one has to suspect this disease when you see people suffering from arthritis with a viral disease and investigate. Important thing is in Chikungunya, when you have an antibody which is positive, every disease there is an antibody which comes initially, there is an IgG which turns to IgM. But in Chikungunya, it is a disease where it remains IgM throughout the life. IgM antibody agar banti hai body mein, so that remains same for whenever you check, it is always IgM. It rarely turns to IgG. So Shripad, would you like to comment something about treatment and prevention of Chikungunya, if you have to say something?
Yes, जैसे कि बताया गया है, डॉक्टर कुलकर्णी, मोदी और बाकी लोगों ने बताया, ये वो वायरसेस है जिनको अभी तक जैसे बैक्टीरिया यानी जीवाणु में एंटीबायोटिक इस्तेमाल करके उसको मारा जा सकता है, उसी तरीके से सिर्फ गिने चुने वायरसेस यानी विषाणुओं पर एंटीवायरल्स का खोज हुआ है. जैसे डॉक्टर कुलकर्णी ने कहा, हर्पीस, अपने जो शिंगल्स का वायरस रहता है नागिन का, उस पे है, HIV, कोरोना और चंद गिने चुने वायरसेस में है एंटीवायरल्स उपलब्ध है. लेकिन ना डेंगू पे है ना चिकनगुनिया वायरस पे है. इन दोनों पे भी एंटीवायरल्स ऐसे कोई उनकी खोज नहीं हुई है, इसलिए शरीर से उसको खत्म करने के लिए कोई दवा नहीं है. चिकनगुनिया की ट्रीटमेंट जो है वो अगर मरीज को बदन दर्द यानी मसल पेन, जॉइंट पेन, ज्यादा बुखार चढ़ रहा है तो पैरासिटामोल और पेन किलर दवाओं से उनकी जो तकलीफ है उनको दूर करना चाहिए. चिकनगुनिया में ये सारी दवाइयां दे सकते हैं. जैसे डॉक्टर मेश्राम ने कहा कि कई लोगों में बाद में स्नायुओं में और जोड़ों में जो दर्द रहता है वो महीनों तक चलता रहता है. अगर वो कुछ हफ्ते तक रहा तो पेन किलर्स जैसे अपने ब्रूफेन, नैप्रोक्सिन, जैसे मोदी साहब ने कहा, उनको इस्तेमाल करके इनकी तकलीफों को दूर किया जाता है. लेकिन अगर वो हफ्ते महीने चलता रहे तो इन लोगों में चिकनगुनिया में स्टीरॉइड्स का इस्तेमाल किया गया है कुछ महीनों तक, और स्टीरॉइड्स से काफी राहत मिली है मरीजों को. स्टीरॉइड्स के साथ साथ कुछ मरीजों में ये बदन दर्द ज्यादा देर, बदन और जोड़ों में दर्द यानी जॉइंट पेन ज्यादा देर न रहे, इसलिए आप सब लोग जानते रहोगे, हाइड्रोक्सीक्लोरोक्विन नाम की एक दवा है, उसको शुरुआत में कोरोना में भी बोलते थे उसके बारे में, अभी ज्यादा उसका इस्तेमाल नहीं. लेकिन इस तरीके की दवा जिससे ये जॉइंट पेन, मसल पेन ये बाद में शरीर में ना रहे और निकल जाए, इसके लिए इनका इस्तेमाल होता है. और बाकी जो डेंजरस कॉम्प्लिकेशंस है, जैसे डॉक्टर कुलकर्णी ने कहा, अगर ब्रेन स्वेलिंग होता है जिसे हम एनकेफेलाइटिस कहे, तो उसमें अगर कोई वायरस के बाद रहे तो कुछ दवाइयां है स्टीरॉइड जैसे, नहीं तो उनको सपोर्टिव ट्रीटमेंट देते हैं, उनको आईसीयू में रख के उनका कॉन्शियसनेस लेवल अगर कम हो जाए तो ऑक्सीजनेशन या उनके ब्रीदिंग में प्रॉब्लम है तो उसको सपोर्ट किया जाता है। अगर डॉक्टर मेश्राम ने जैसे कहा कि स्पाइनल कॉर्ड या नर्व्स में माइलाइटिस या न्यूरोपैथी हो जाती है, तो अगर बीमारी के साथ है यानी बुखार के साथ तो उनमें स्टीरॉइड्स देते, बुखार के बाद आती है तो कई बार कुछ ऐसी दवाइयां है जो स्वेलिंग यानी सूजन को कम करती है। तो इस प्रकार से इस बीमारी को ट्रीट करते हैं। और बाकी सपोर्टिव ट्रीटमेंट, जैसे इमरजेंसी में पेशेंट आया तो उसे हाइड्रेट अच्छी तरह से रखना है, उसको बहुत सारे लिक्विड्स देने के लिए रिश्तेदारों को कहना है, सलाइन से भी अपन फ्लूइड्स देने हैं, पेन किलर्स देने हैं और उसकी तकलीफें दूर की जाती है। प्रिवेंशन के लिए जैसे डेंगू और इसका जो मच्छर है मस्कीटो सेम है एडिस, तो जैसे डॉक्टर मोदी जी ने कहा वैसे ही पानी के साठे जहां भी है उनको इकट्ठा होना आप बंद कर देना। बगीचे में, गैलरीज में, जहां अपने जैसे पेड़ पौधे उगाते हैं वहां भी अपन पानी डालते हैं, वो दिन ब दिन वैसे ही रहता है, वो फेंक दे, वो बर्तने उल्टी रखे, वो साफ रखे। आजू बाजू में अगर बस्तियों में पानी कई लोग भरते रहेंगे तो उनको भी मना कर दे, और खिड़कियों में जालियां लगाए, मच्छरदानी लेकर सोए ताकि, और मस्कीटो रिपेलेंट्स जैसे इंसेक्ट रिपेलेंट्स है वो लगा के सोए, और मच्छरों का अपने घरों में आना प्रिवेंट करे, मना कर दे, ताकि एक बात है कि अपना जैसे ओमिक्रॉन अभी जो स्ट्रेन है आप देख रहे हो कि जल्द से जल्द फैल जाता है एक के दूसरे से, वैसे ही चिकनगुनिया है, जैसे डॉक्टर मेश्राम जी ने कहा, एक मरीज को अगर घर में हुआ तो सारे सोसाइटी में वो फैल जाएगा। इसलिए हो सके तो उस मरीज को भी एक 5-7 दिन जब तक वो वैसे भी एडमिट है तो उससे नहीं फैलेगा, और जिसको सिर्फ बुखार है वो दूर रहे, वो भी उसको मच्छर ना काटे ताकि उसको काट कर वो बाकी फैमिली मेंबर्स को भी दे दे, ये भी ना करे आप। मैं कहूंगा कि इस तरीके से इसे प्रिवेंट कर सकते हैं।
घर के अंदर के जो मच्छर है उसके लिए वो अभी वो इलेक्ट्रॉनिक टेनिस रैकेट जैसी बैट है, दैट इज क्वाइट यूजफुल है। वो घर के अंदर जो घूम रहे हैं तो वो थोड़ा सा घुमा देते हैं तो वो घर में जो जितने मच्छर है सब मर जाते हैं, and then you can sleep peacefully.
Sir, I want to ask a question here. Chikungunya has some geographical predilection in India. It's more so in Western and South India.
Yes,
because
when the virus reached India, it started from southern part. That it started from Kerala, went higher up to I think Gujarat and Rajasthan. Some cases were also reported. Spikes were reported from Delhi, but I don't think it's reached to the northeast part like UP and Bihar. आपके एरिया में
I've seen very few number of cases so far in my clinical practice.
Central and southern part was the worst hit part. When 2006, 2005 we saw the cases, we had the highest number. Probably we had one of the largest series which we published that time long ago.
So most of the publications are from South and West India.
Yeah.
But this time, sir, Rajesh Verma, sir, even Punjab documented a very high incidence of chikungunya this rainy season. I'm talking 3-4 months back. Confirmed diagnosed cases, lot of them from the samples received in PGI. Lots of them from. See, the virus is different, but the host, the spreader is the same. The same Aedes virus, same circumstances, same season. It is only that, we are a global village now. We imported it from, and it hardly takes from our jet planes and from our cargos to spread, the disease. And there is no way, so if you get dengue, you get chikungunya. So I don't find whether they are brothers and whether they are cousins, not brothers and sisters.
I totally agree with you. Because as on today, we are obsessed with this COVID-19 disease.
Yeah.
So we are not thinking.
So we have.
But we should come out now, and of course, you are giving us an alarming bell that we should also look for chikungunya in our part.
Yes, we have to be proactively looking at it. See, what happened, why the suspicion was raised high? Dengue fever, platelet counts normal. So what is happening? The symptoms are the same. There is hardly any difference. Body pains, high-grade fever, and all that thing. And then we proactively collected samples and found chikungunya is the culprit in these patients. That is how we came to know.
Yeah, possibly the same vector competition is there because both have got the same vector. So
exactly.
the vector competition is there.
So I like that idea of bringing the competition by a bacteria to this mosquito. So let our bacteria fight the viruses which is contributing.
There are people who are working.
Said that this Wolbachia bacteria is not it is harmless to man, and it's a common 50% of the mosquitoes are infected. It is the infection of the mosquito, so it just keeps on killing the mosquito and prevents us from the diseases.
Correct.
So I think that time is not far off. You will see it, sir.
there is some data on some dengue virus which has been mutated virus which doesn't affect human to a severe extent. So those viruses have been injected in the Aedes, and then the Aedes bites human, and you get dengue infection, which is a mutated. So it's like vaccinating. It's like Omicron, which is a less severe compared to Delta. Similarly, people had worked on dengue when the vaccine was not a feasible option. This was an option which was thought of. You have a mutated virus which is injected to or infested to human through the Aedes aegypti. So so those kind of options will be useful probably in future. But yes, so talking about these arboviruses, we'll just wrap up this session on arboviruses. So we know that this is an area where there is no treatment option available. These are the viruses which are rampant in India. Probably India would be called as hub of these viruses, and we need studies, treatment options, and algorithms about management about these disorders from our country. And tropical neurology and IN at a large extent would work on this to find out some answers to these unanswered questions. So I think we'll move ahead. Shall we go to cystic sarcosis, or do we talk about some couple of other disorders?
About Japanese encephalitis, it is not very common in western part or the southern, but Japanese is quite common in the eastern India and in central India.
Yes. And we have various disorders in various geographical locations in India. The epidemiology of the viruses is a big chapter and big topic of discussion. We may have some discussion on viruses some later time. So maybe we'll go to cystic sarcosis. Manish, would you like to take up cystic sarcosis?
Yeah, sure. Thank you, Rahul. Actually, Dr. Gagan was busy and he was not able to log in. I have sent him a link. But in the meantime, just to save we are already running a bit behind the schedule. So we talked of two very great viruses spread by a tiger mosquito. Now we are going to altogether different manifestation, which is quite rampant and quite endemic and has epidemic proportions also in India. We are not able to still take care of this disease, which is totally again preventable and curable. And it's a big disease burden on in India. And I would just like to share that I would like to discuss briefly about what is neurocystic sarcosis, how it happens, and how we can prevent for every one of us and for the general public. And are there any recent breakthroughs? So as I start, I hope Dr. Gagan will join in the meantime. So how I got interested in this particular topic, which, I worked with Dr. Gagan also on this in a big way earlier, that it was, in Punjab, it is called Gobi ka Kida. And I'm sure most of you are also aware. And how common it is with the name of Gobi ka Kida, I can tell you that people feel that it is the worm which is present in the cabbage. And people have stopped eating cabbage in Punjab because of the fear of neurocystic sarcosis. So this is, and why it is called, then we came into the, Why exactly was it called Gobi ka Kida? Believe me, there are quacks in and around in Punjab and adjoining states where they, put in a pipe in the nose of the patient and they take out a worm, which is quite similar to the worm which we see in Patta Gobi. Aapne wo hare keede dekhe hain. So they put it in a bottle and tell them, look, I have taken this out. Now you get your scan repeated after 3 months, it will not be there. So look at the beauty of the, and you will not stop any treatment which has been started by the doctor. So many of the patients, I'm talking of 2003, 4, 5, used to come with those bottles कि डॉक्टर साहब देखो आपने बताया मेरे दिमाग में कीड़ा ये देखिए हमारा कीड़ा निकल गया अब मैं आपको 3 महीने बाद दिखाऊंगा मेरा कीड़ा गायब होगा फिर एक को डॉक्टर ने बताया पर मैंने आपकी दवाई नहीं छोड़ी. So this is how it evolved. And I'm sure if Dr. Gagan joins, he has much more such stories to share than me. And this is how, I got fascinated how to, really take them out of this myth. The worm which is given to them is almost 2 to 2.5 centimeters, big worm. And what we are seeing in a CT is a very small ring enhancing lesion, which is nowhere near the worm which they are carrying along with. But that is the kind of myth, and even you won't believe the very qualified and elite class of the society also goes to those quacks once they come to know that it is neurocysticercosis. It is so prevalent with the name of Gobi ka Kida. So taking further lead from this, my brief introduction about this fascinating worm, as advised by Dr. Meshram, I have just made few slides just to give an overview of how exactly this infection is happening. There is still some confusion even amongst we physicians also, which some finer points I want to highlight. Mansi, can we have the next slide, please? Yeah. So this is what we all know, that neurocysticercosis is caused by the inflammation around the cyst, which has gone astray into our brain from the intestine and lodged there. And when there is a response, immune response to this cyst in the brain, that we get symptomatic epilepsy. And NCC, it is not to our surprise, is one of the most common cause of epilepsy or treatable cause of epilepsy in India and in many low and middle income countries, and is one of the major, major health burden in terms both in economy as well as in terms of morbidity as well as mortality also in our part of the world. And may I have the next slide, please, Nancy? Yeah, so this is what I was talking of. We all know that after 3 months with or without albendazole and steroids, in majority, this will keep on shrinking and disappear. So these were the strange disappearing lesions which were discovered way back in 1980s, 89, 90s, and then were finally proven to be neurocysticercosis by Dr. Rajshekhar, and then that changed the whole game. Earlier, everything which was ring enhancing on CT was treated as tuberculosis, and once with this landmark paper and with the disappearing lesions, this disease came into proper light, and that is how people started looking at and started differentiating it from CNS tuberculosis, where people were given anti-tubercular therapy for years or 18 months together, and then people found that it can be just taken care by steroids or steroids with albendazole. Next slide, please. So, and if we see, the disease burden is amazing. Short of few developed countries, it is prevalent almost everywhere in most of the low and middle socioeconomic status countries, and even in developed countries also, people who are migrating there, they are carrying the worms and they are carrying the bad habits, and they do get occasional 1 or 2 cases odd in their practice, which we commonly see as 1 or 2 cases every week. Next, please. And same is true for India, except for regions where pork eating is not prevalent or is not considered from a religious point of view. Most of the part of India is, having, especially where pork eating is prevalent, it is quite prevalent. And we can see all these areas, central India, and it is all full of neuropsychosis. Next. So how do we get it? How do we get it? Next slide, please. So if we see carefully, can I have the next slide, please? Yeah. So this is the life cycle which Dr. Mishra wanted all of us to just ponder. And if we see that the life cycle, the definitive host is man. We are the carriers of the worm. It is not that we are blaming the pig. Actually, we know that the habits of pig, because they are coprolilic, they are in unhygienic places. They eat human and feces, and that is how they take the eggs which are passed on by the tapeworm, which is there in the human intestine. So the worm is in the man, but the cyst which is there in the brain is because of the eggs. So normally the human feces, how is this life cycle actually continuing? The human feces contains the eggs. The pigs are eating those feces and ingest those eggs, and those eggs, they get deposited in the muscles of the pig, what they call as measly pork, right? And this is what has been shown in the picture also, that this measly pork, if eaten raw by another human being, or not properly cooked or not properly treated, then the man will get the infection and will get this measly pork will bring in new tapeworm in another human being. So this is how the cycle in the nature is going on, that man is carrying the main worm and pig is carrying that. Pig eats those eggs thrown out in the human feces, and they get deposited in pig flesh, and that pig is measly pork is eaten by somebody, some other human being, and this is how other human beings are getting infected, and that is how the disease is endemic in regions where pork eating is prevalent. But when we talk of neurocysticercosis, it is not because of the eating of measly pork. It is because of the contamination of food, other food, like our vegetables, by human feces. Now, how can that be possible? That is possible if, you have seen many of the fields, they are, cultivated by sewage water. So that is how, it is not gobi, it is not only cabbage. It is any vegetable which is grown under the soil and which is contaminated by human sewage or human feces or by open defecation is going to have the eggs of Taenia solium. So it is not gobi, it is not gajar, it is not shalgam. Any vegetable which is underneath the soil and has been contaminated by human feces, which is infected, is bound to have the cysticercal eggs. And if we are not careful and we are eating those raw vegetables without properly washing, now here comes the importance of washing your vegetables. If we are not washing them properly, we are bound to get some of the eggs which, after passing through your intestine, are going to land up anywhere. It can be in the skin, it can be in the muscles, it can be in the eye, it can be in the heart, or it can be in the brain. So anywhere it can go. So man is an accidental host for these eggs. It is not by nature it was decided. Now, what is the other way? So we implicate cabbage. Look at what is happening in the parties. In big festivities, we have one big drum of water where we commonly see that quintals of vegetables are washed. That is how the community spread of serving salads in various festivities, in various parties. That is how, through partially cleaned vegetables, we are getting those raw vegetables, we are eating them. And that is how we are acquiring these eggs and eating these eggs. Neurocystic cirrhosis. The other common thing which has come to our light, one was this infected vegetables. The other is the poor sanitation measures used by our cooks, by rasoias, by the cooks in the kitchens, in big kitchens. Say we come across at times 8 or 10 students from the same canteen, from the same school, from the same university. Suddenly, why? Because their cook was not cleaning his nails properly. The clipping of nails was not proper. They were not using proper hand hygiene methods, and they were spreading eggs in the same vegetable to lot many of people. That is how we are getting exposed. So this thing is very important. Man is an accidental host of neurocystic cirrhosis, but because of the bad habits, I can say, or bad measures adapted by man. I hope I am clear. Mishram sir, you would like to add something to my cycle?
No, it's fine. I think
I have made my point clear.
Gagan is also joined.
Oh, then it's okay. Then I am not. I request Dr. Gagan to. I'll just ask Mansi to go to the next slide, and I request Dr. Gagan to take further my discussion.
Dr. Manish, you have beautifully highlighted the whole life cycle of Tinea
this
solium.
is what I want to show.
I think that is a very key point which we have to understand. So I think you have beautifully highlighted that man is the definitive host, pig is the intermediate host, and then man gets neurocystic cirrhosis accidentally, either through retrograde retrograde transmission of the eggs, or through poor hygiene. Which so might be direct or indirect through food handlers or self-poor hygiene. So I think that you have beautifully highlighted. I think you should continue with your presentation. I want to listen to it. Please carry on. Please carry on.
Okay, sir. Okay. Anyway, so I have just 1 or 2 slides to just apprise how exactly can neurocystic cirrhosis really manifest. Can we have the next slide, please, Mansi? So
yes, sir. If you can just give me a minute.
Sure.
Just
no problem. Minute, no problem. So, or I can share my screen. Okay. So what is so neurocystic cirrhosis? The most common we see is epilepsy. Though it can cause many other problems, that depends upon where the cyst is really there in the brain, where it has gone. It can lodge in spinal cord, it can lodge in meninges, it can produce strokes, it can produce, hydrocephalus, it can be really life-threatening, and it can be in the brainstem and produce multiple cranial nerve palsy. So literature is full of all kinds of manifestations of myelopathy, of strokes, of multiple NCCs presenting as dementias and things like that. So, but the problem is that despite so much of awareness about its life cycle, we had been seeing an increasing trend. There is no, I mean to say, despite knowing everything, there is no looking back. The number is almost the same or is steadily increasing and affecting every age group. Only day before yesterday, it was a 74-year male who just came with a very small, ring enhancing lesion, first episode of seizure, you do bloody PET, MRI and whatnot, and it turned out to be NCC. So it doesn't have any age, and you can see it even very young also. So it is a big burden and is one of the most common and easily treatable cause of epilepsy. We can have the next slide, please. I just wanted to show 2 slides and then I'll ask some firing questions from Dr. Gagan. So this is the common manifestation, so easy to diagnose. And if you have a classical picture of a ring enhancing lesion with a Scolex inside, there is no differential diagnosis and you straight away conclude it is nothing but NCC and start treatment along with the anti-epileptics, and you get reasonably good outcome in good 70 to 80% of the patients. One more slide I think I have, Nancy, next slide please. And okay, so MR definitely is an investigation of choice because it gives you much more information about the number, the site, whether you have missed something, whether it is safe to give albendazole and all. And the last slide please. And if a situation like this happens where the whole brain is treated, then you are worried that whether to give albendazole or not and how to treat these patients. So meaning thereby, I just want to say that neurocystic sarcosis is an endemic disease, a major disease burden in India, and is creating a big problem for us to manage, which can be easily cured by prevented. I mean to say by taking simple measures like hand hygiene and washing your vegetables. That's it. And taking care of measly poke. If we are able to break it, if they can do it in Peru, why can't we in India? I have certain further points, but I would now request Dr. Gagan. Is there first of all, sir, in your experience, what is the cure rate we expect? I mean, say epilepsy, they say you have to continue for 3 years, but what is your experience when it comes to neurocystic sarcosis as a cause of epilepsy?
Thank you, Dr. Modi, for those wonderful slides and for making a lot of things very clear. I have some very fond memories of working with you very closely on this. And not only that, I mean, so many of my colleagues, and I remember that when I had completed my training as a neurologist, so I came from PGI Chandigarh, came to Ludhiana, and I met a parasitologist in the veterinary university in Ludhiana, and we became very close friends. And cystic sarcosis was an area of interest for him too. And believe you me, what we would do every Sunday, हर संडे को हम क्या करते थे कि लुधियाना में एक नाला है, उसको पानी का दरिया है. There is a small stream, but it is very famous, and it is called as Buddha Nala. And it is supposed to be the dirtiest place in Ludhiana, one of the dirtiest places. It is full of sewage water. So Dr. Jual, who was the chief of parasitology in the university, and myself, we went and we used to collect samples, and we would spend about 1 hour collecting these samples. And so this is about 25 years ago. Yeah. And then the next day, Dr. Jual would examine all those samples and try to look for Cysticercus eggs. Cysticercus is a tapeworm, so he would look for tapeworm eggs. And there is a special process or a staining process which is used for looking at tapeworm eggs. Hello? Yes. Right. Am I audible?
Yes, sir.
I thought there was a blip. Yeah. And, every day after his, microscopic inspections were over, he would say that I could find a lot of roundworm eggs. And roundworm is another form of worms. There is, these are smaller worms and different from tapeworms. And he said, I would find a lot of roundworm eggs, but I can never find a cestode or a tapeworm egg. And likewise, about the same time, Dr. Peter Shantz, who is
I think sir is facing some network issues.
Yeah, I think so. Anyway, till the time he joins,
I think he has joined us.
Yeah, right.
Sorry. So Dr. Peter Shantz, who is a neurologist in hello.
Yes, sir. You're audible.
Right. So Dr. Peter Shantz, who is a parasitologist based in CDC, they performed lots of tests on vegetables, and they really could not find too many, tapeworm eggs. So what they say is actually cysticercus is transmitted due to poor hygiene, poor hand hygiene. People do not wash their hands after ablution. People do not wash their hands before eating meals. And the other thing is what Dr. Modi emphasized is being careful about the kind of pork. Fortunately, in India, there are not too many pork eaters. But those who do eat pork need to be careful about where they purchase their pork from and what is the type of pork that they eat. Are they from certified, pork producers? If that is the case, then there should be no problem. Otherwise, there are a number of, non-certified pork producers which will not, conform to the pork, healthy pork producing habits, procedures, and that is what creates the problem. So I think these are some simple, and Dr. Modi has said, I mean, once the epilepsy occurs, once the seizure infestation occurs, it is very difficult to treat, right?
True, sir.
However, we can very effectively primary prevent. Primary prevention is very simple. It is really cost effective. And therefore, I mean, the experience of countries like, many countries in Europe, Germany, England, Spain, Portugal, Italy, all of them in the 18th century had lots and lots of cysticercosis. But all of that has disappeared just because of good hygiene, sanitation, and good pork production practices. So we have to follow that example.
Right.
So I think, and another important aspect is that the small part of the worm, which is called proglotid, which is excreted, that is maybe 1 centimeter, that small part contains about 20,000 to 40,000 eggs of cysticercus in that small part. So that excluded. So that's the density of, number of eggs in the feces. And it is said that the pigs, they like the human feces. They like to feed on the human feces. So another aspect of sanitation is, that open air defecations, we can take control of that, and they should be banned. And then we construct the toilets for the people, mainly from there are no toilets in the villages. So I think the cysticercus, the problem of cysticercus, we can tackle just by creating the toilets.
Absolutely.
Toilets.
Absolutely.
Yeah. That is a very important point. That is an extremely important.
So, Dr. Gagan, there was another interesting aspect to the handling of measly pork. They call, I think the term learned from you was dane. We used to collect dane from pigs, and we had been collecting for our research. Of late, we could grow these cysts and tapeworms in our laboratory, in our parasitology laboratory. Of late, we could manage that, and we are developing a PCR to ease the diagnosis where there is a confusion. So it is still under development, but that's another breakthrough which PJ may be able to give in the days to come. They are actively working on a PCR for diagnosing. So that was another of my point, that sometimes the radiology can be challenging and the patients are treated like tuberculosis. Then in such situations, how do you go about it? How do you decide whether to give ATT or to give anti-helminthic treatment? How is your protocol? I would like that your experience be shared with the neurologist and even with the general public. There are many neurologists around who are listening to our talk.
So Manish, you are an expert in tuberculosis, and there are occasions when we have these, since this is a public forum, so sometimes the imaging or the MRI or the CT scan between the two conditions can be really, really very confusing, and you have to exercise a whole lot of clinical judgment. If there is one thing that is extremely, extremely helpful in in saying that, yes, we are dealing with cysticercosis is the identification of a scolex. So if we are able to identify a scolex, then we can be quite sure that we are dealing with cysticercosis. However, at the same time, having said that, it is also important to realize that a scolex is present only in the early stages of a cysticercus.
Right.
So a cysticercus, when it lodges in the brain, goes through a series of stages, evolutionary stages. And the scolex would be seen only in the early stages, that is live stage, or it is known as a vesicular stage, and the colloidal stage. In the granular nodular stage, you generally do not see a scolex. So then it can be an issue of confusion. There are a whole lot of criteria, but nothing is absolute. Size criteria, Dr. Rajshekhar from Vellore emphasized size. When it's less than 20 millimeters, cysticercus more than 20 millimeters, likely to be tuberculosis. But at the same time, Dr. Rajshekhar also, and including besides our group, we published cases of cysticercosis which were larger than 20 millimeters.
I know, sir.
So there are, it is indeed a challenging and a difficult work.
I understand, sir. Another important question, do we have a vaccine like we talk of in COVID, and do we have any vaccine for cysticercosis?
So yes, there are vaccines, and vaccines are of, can be directed against human beings and the pigs.
Yeah.
Most often the vaccines which have been used and are now being used commercially also being available. There are trials of these vaccines in large amounts in the states of Assam, Uttarakhand, and some of the other northeastern states, and these trials have been really successful. So porcine vaccination is what is a very interesting avenue or interesting way of eliminating cysticercosis.
Yes.
So not only porcine vaccination, but porcine chemotherapy is also there. So there is another new drug, oxfendazole.
Yes.
This is besides albendazole and praziquantel, and oxfendazole is much more, 20 times more potent than albendazole, and it is used to treat porcine cysticercosis. You give it to the pigs, and all the cysticerci in the pigs get eliminated. Almost all the cysticerci get eliminated. In fact, having been used in pigs so extensively, now there are some trials of this drug being used in human beings also. So they have done some preliminary pharmacokinetic studies in Peru, feeding human beings with oxfendazole, and it is being tried as a treatment for human cysticercosis also. But so both porcine chemotherapy and porcine vaccination. And porcine vaccination, there are now at least 2 or 3 different types which are commercially available in India.
I thank you very much. I actually wanted to highlight that only, that at times, you have to really be more proactive to prevent this disease from spreading in the community. And that's a big thing.
Yeah.
Thank you. I think, Rahul, we have already crossed that time limit. And I think neurocysticercosis is something which you can discuss even for 2 days. So, but if I think we can take up some questions from the chat box and can fire it to the panelists. Will you take over, Dr. Rahul, now?
So I think most of the questions have been answered. It probably was a wonderful meeting, and we had some questions which have been answered during the discussion. We talked about chikungunya, we talked about dengue, we talked about cysticercosis. So 3 important disorders which are pretty common in our country, which are often neglected, And these are very common disorders which can be easily prevented, and these are preventable disorders. So it was a good discussion. Dr. Gagandeep Singh, sir, would you like to wrap up saying something before we hand it over to Dr. Meshram?
So I would just like to most of all, I would like to congratulate you, Dr. Rahul Purkarni and Dr. Manish Modi, as well as Dr. Meshram. Dr. Meshram is like the emeritus professor of tropical neurology for us. So extremely important. So congratulations for having thought of this important topic, all these three topics. Congratulations for having thought of neglected tropical diseases in relationship to neurology, and for the initiative to create public awareness about them. So it's indeed a great task, and hats off to the three of you, as well as all others who have contributed to this meeting immensely by increasing knowledge, increasing awareness amongst the public, as well as the neurologists. It's very important that all of us also need to know about the public health aspects of these infective neurological disorders, because that is how we can truly contribute our bit in improving the society, in improving reducing the prevalence of these diseases, reducing the burden of these diseases. So it's not just important to treat them, it's also we have to play a part in reducing the burden by preventing these diseases. And I think that is what the emphasis of today's important meeting, highly important meeting, is. So hats off, congratulations. Please accept my compliments on a very successful short session, but highly successful in conveying what you intended to convey. Over to you, Dr. Meshram. And the other thing I want to mention is, as a group, we from Tropical Neurology are extremely proud that Dr. Meshram, who had led the Tropical Neurology Initiative, particularly during the COVID times and in the recent years, has been nominated as a trustee of the World Federation of Neurology. So that's a big achievement. Not only personal achievement for him, it's a big achievement for all the neurologists of India, and we are all with you. And we know that with Dr. Meshram around in the WFN, tropical neurology will get its due place, what it is supposed to get in the proceedings of the World Federation of Neurology and the conferences which are associated with the WFN. Thank you.
Thank you, Dr. Gagandeep Singh, and it's a great moment, and it's all the teamwork that we are doing together, and it's an achievement for the team, and I think we are able to make the impact in the society, and I think today's session was excellent, and we had planned about 10-15 days before. 2 days back, I received a mail from the WFN, past WFN President, Professor Raj Shakir, and it was, copied to WFN President and others in the Latin America and Africa. And he says there is a neglected tropical disease World Day on 30th, and it is quite late. But if you can organize a meeting, and I told him that we have already organized a meeting on 30th, and it is already that we have planned and the whole discussion, and he was quite happy that we already took this initiative to get along with this well. And when we did the Inspiring People in Neurosciences, and last time we had talk by Professor David Molyneux from Liverpool, and his topic of the talk was neglected tropical diseases, and he did extremely good work. And I would like to thank Rahul Purkarni, Manish, and Nirmal Surya and IAN for giving this opportunity in carrying forward this word, and all the panelists, Shripad, Devashish, Dr. Verma, and Meenakshi Sundaram, Sita Jailakshmi was here, Dr. Gagandeep Singh, for being part of this very important session, Manish Modi. and the IN for the, putting this first activity of the year in process. And we meet for the next activity, which is on 14th February that is just Monday. For second Monday of the February month is called as International Epilepsy Day. So we will have discussion on the epilepsy. And thank you very much. And I think we had a very wonderful session, and I think people would have enjoyed and cleared some aspects about the diseases. And as Dr. Gagandeep said that we have to focus on prevention. And when I talk about public education, I give my punchline is that my health, my responsibility. Everybody has to take care of his own health. So if you take care of your own health, I think the most of the problems we can take care, and we can reduce the incidence of any diseases in the society. Thank you very much.
Thank you, sir.
Thank you. And we declare this session is closed. Thank you, everyone. Stay safe. Thank you.
Thank you.
Thank you.
Thank you, sir.